Welcome to FYI. I'm Barry ZeVAN, and today I'm honored to have my guest, Ed Ehlinger, who is the former Commissioner of Health for the state of Minnesota and is a doctor of internal medicine as well as pediatrics. And Ed, it's wonderful to have you here today.
Well, it's good to be with you. Good to be with you.
Thank you, sir. You've had a long career.
That means I'm old, yes.
No, not as old as I. But anyway, to me it's fascinating because you also have been in the political realm, serving as the state's Commissioner of Health, but also you do some other things now that are even on a national scope. What are they?
Yeah, after I left my position as the Commissioner of Health, I started working with the Health and Human Services Secretary at the federal level, working on infant mortality. And I'm also working with some public health institutes out of California, working on how to build a public health workforce throughout our country. So I'm doing some work with them, and in addition to doing some work with foundations and various other committees here in Minnesota.
Wow, so you're busy. You're busy.
As busy as I need to be right now.
That's great. Healthcare, we are going to get into a little bit of politics today because as some of the viewers know, I've had some little bit of experience either internally or on the fringe. But healthcare seems to be one of the major subjects, especially the Democrats are pushing for the election next year, 2020. And to me, it should be a no-brainer because of what we pay. I'm very blessed, thanks to the Korean War, to get all my medications from the VA and all my medical work. And they've been fantastic here in the Twin Cities. But I can't even imagine what people are going through. Well, I can imagine because I kind of went through it years ago, but not to the level of distress that people are going through now to either decide whether they're going to eat that week or they're going to pay their medical bills that week. What can be done about that? And especially comparing our medical system to a lot of the rest of the world. I have friends in countries, well, Denmark and the UK, who say, well, it's socialized medicine and we have to wait a while to get our appointments, et cetera, but we pay very, very little for medical care or anything at all. What are your opinions?
Well, you raised some really good points. Access to health care is really important. It contributes a lot to our health, but not as much as most people think, and I'll get to that in a little bit. But I believe that access to health care is a right. It's not a privilege, because we all benefit from, we all need people to be healthy. And in our society, we want everybody to be healthy. So everybody should have access to care. Right now, not everybody has access to care. And that's where politics comes in and where political will comes in. And as you pointed out, we're spending way more than any other country on health care, and yet we're getting poor results. We have 30 to 50 million people who don't have access to care at all, and another 30 to 40 million who have poor access to care or not as high quality of care, sort of underinsured. And that really is a dark spot should be on the conscience of the United States. So we need to have a conversation about, is it a right or is it a privilege? And I think most people believe it is a right. If it is, then it's a public good that we all should support. And we need to find a funding mechanism that assures access.
Now, something also has puzzled me regarding polio. I'm from Pittsburgh originally, and Pittsburgh's Dr. Jonas Salk created the polio vaccine, but all of a sudden it's back. I'm puzzled as to, because we, quote, have a cure, and maybe that's in quotes, but I think it's real, of course, for years. Now all of a sudden it's come back. Why can't the vaccine be used to make it not happen again?
Well, we've eliminated polio in the United States, and most other countries have eliminated polio. There's only like 3 or 4 countries where polio has started to rise its head again. And these are places where the system is not set up to make sure that vaccinations occur. And a lot of it is because people see vaccinations as sort of Western intrusion onto their health, and so that it's sometimes dangerous in some countries, particularly like Pakistan, to be a vaccinator because your life is at risk. So though in those places where the vaccine rates have gone down, that's when we're starting to see a resurgence of polio. We can cure it. We can prevent it. And we have the mechanisms of doing that. We just have to make sure that in all countries of the world, in particular the 3 or 4 countries where we still have a few cases, that the political climate is such that we allow vaccinations to happen without the risk of the vaccinators being injured or killed.
Thank you. With your long history in medicine, I would assume you've traveled to other countries and possibly studied what they do and how they do it, etc. If so, what are the comparisons between some other countries to which you've been and here in the United States?
We always go to that comparison with other countries, and because it's always about health care. And certainly other countries, particularly the European countries and particularly the Northern European countries, where they have a single payer healthcare system where there's governmental funding for care, provides better outcomes, better access, and at much lower cost. And we could use those as a model. But the things that I find most important really started when I first went into medical care. I was going to be a doctor in a small rural community. And so I actually worked with the National Health Service Corps in Montana for a couple of years. And I was seeing 30, 40, sometimes 50 patients a day in these small towns. And I realized I could be treating those individuals every single day for the rest of my career, and it wouldn't make a bit of difference in the overall health of that community. It would help those individuals, but it wouldn't improve the health of the community as a whole, because there was too much violence in the community, too many drugs, too much alcohol, too much tobacco, too many occupational injuries. And I realized, well, then there needs to be something else, more of a public health approach where we look at the population as a whole. So I went back and got some training in public health, and then brought that to Minnesota when I came here to work with the Minneapolis Health Department working on maternal and child health issues. But I also realized even that with our best medical care and our best public health care, we still weren't reaching the goals that we needed, because some of the policies that oversaw a lot of our systems really didn't actually enhance health. Policies related to housing, policies related to transportation, policies related to economic development, policies related to incarceration. Those policies got me really interested into being into a more political setting. Even though I'm not a politician, I worked in a political setting, really realizing it's the policy issues that really impact health. Healthcare only accounts for about 10% of our overall health. It's the living conditions of people that accounts for probably 50 to 60% of our overall health. And yet we spend way too much money on the care part and not enough on the prevention part.
Are you optimistic that that might happen, to focus on the last?
I'm getting more optimistic as we see a new breed of physicians and nurses and healthcare workers of all coming up with a more social justice perspective than a purely clinical perspective. And they're starting to say we need to address not only the physical and mental conditions of treatment, but we also have to look at living conditions. And I think we're starting to get a new breed of professionals who are starting to do that. We're also seeing that communities, particularly communities of color and low-income communities, recognize that they've been sort of set to the side and their needs haven't been met. They're starting to gain some power to actually influence policy change. And particularly in Minnesota, where we've gone from, when I moved here in 1980, 2% people of color and American Indians to now nearly 20% people of color and American Indians, and going up very rapidly, that unless we deal with this social and economic and cultural aspects of care of the communities in which people of color and American Indians live, we're never going to really be a healthy state. And so they're gaining power. We're starting to recognize the need to deal with these equity issues, and we've got a bunch of professionals coming on board that really want to deal with what we're calling the social determinants of health. I'm optimistic that eventually we're going to get there.
You mentioned Montana. During my early broadcast career, I started in Helena, and then Missoula, and then Kalispell, then Anaconda, and then out of the state. Were you from Montana
No,
originally?
I'm originally from Wisconsin.
Ah, I see.
But I saw Montana as a place to really practice rural health care, and I learned a lot while I was there.
Yeah, it's because it is such a huge state, third largest behind Alaska and Texas. But is it how difficult is it for people who live in rural communities out there if they don't have the blessing of a hospital or a doctor such as yourself, that they have to travel miles and miles and miles to get any kind of help?
Yeah. Well, this is a great example of the struggles we have right now. And as I worked as state health commissioner, really found out there are really major problems in rural communities in terms of economic development and in terms of health. And I argue that industrial agriculture has really been detrimental to rural communities because it's sucked all of the resource, all the money out into big corporations. And industrial medicine, the way we practice it, where we have larger and larger organizations, are pulling resources out of rural communities. And that's why rural communities are suffering. We really need to change our whole system. That healthcare should not be about making profit. Healthcare is about actually improving health. And having a hospital in a rural community actually improves health, but it also improves the overall economy. It may not improve the economy for the large health systems, but it improves the economy of that local community. And similarly, we have food deserts in rural communities because the industrial agriculture says you just have 3 major row crops and you're not growing the other things that can actually support nutrition in that community. So we have to look at how we organize agriculture and how we organize health care to really meet the needs in rural communities.
With your work at the Health and Human Services Department, do you push for that pretty hard? And if you do, what kinds of responses do you get from non-medicine related people who really don't have a clue, in my opinion, and maybe I'm wrong, that about some of these issues you would bring up? How do you convince them?
Yeah. So actually, that was the focus that I had during my 7 years as state health commissioner. Really went throughout the state talking about health equity, the fact that we want everybody to thrive, we want everybody to have the opportunity to be healthy, and nobody benefits at the expense of somebody else. Really trying to reduce the disparities. And I would go around the state, and one of the things I did is I went out and pitched horseshoes with county commissioners throughout the state and talked to them about the role that they played in creating health in their communities. Because county commissioners have access to policies around roads and bridges, policies around education, policies around housing, about economic development. Those are the things that really create health. And as I talk to them about their impact on health, I talk about a health in all policies. What are the health implications of ditches in rural communities? What's the health implications of education in rural communities? What's the health implications of transportation and housing in rural communities? They started to see, they actually had a role in health. And so then they brought the business community together and the agricultural community together. And we started having a broader conversation of saying, we as a community have to come together to create health. It's not about just getting a hospital. That's a piece of it, but a small piece. It's really about changing the policies and the systems and the overall environment that supports health in these communities. It's starting to happen.
What are the differences now, without us getting too political, for the audience, it's not a political show, but we're going to talk about, between the work you may have done prior to the current administration and this administration, or are there any differences really?
Well, there certainly are a lot of differences between the Republicans and the Democrats and how they look at the world and how they see things happening. Certainly, I believe, because I've worked in the public sector all my life, there is a role for government. And the Republicans see less of a role for government, and the Democrats see a little bit broader role. There is a definite role for government because the government is there to protect the common good. And so that's one of the things that we have. But it all, even independent of Democratic and Republican, it is a United States worldview that is keeping us from being most healthy. It's all about the individual rights and individual responsibilities. That you're healthy because you make the right choices about your physical activity and your nutrition and drugs, and you have good medical care. It's all about, but it's really, that's only a small piece of what creates health. The real thing is it's about society coming together. Health is in relationships, health is in communities, health is in families, health is in support of one another. And so we have to change that narrative about what creates health from it's an individual responsibility to it's actually a community responsibility. And both Republicans and Democrats are having a harder time changing that narrative from that individual focus to a community focus.
You mentioned something about vaccinations. We have 4 grandchildren and 9 great-grandchildren, and I won't name names, but one of those does not believe in vaccinating children. And recently, of course, there's been a big push on the news and the information that not vaccinating is not good. And there are no dangers. And how do you argue with people who, and of course I would never mention my grandchild's name who's into not vaccinating, but how would you convince somebody like that that there are no dangers?
Yeah. Well, this is one of those dilemmas. When people have an ideology that trumps the science, sorry for that word, but ideology overwhelms science. It's really difficult to change people's ideology. Certainly the science says vaccinations, the benefits of vaccination far outweigh any of the risks of vaccinations. They are a public good. They keep all of us safe and healthy. And this is where we, again, have to change that narrative about it shouldn't be just about individuals making a choice. They have to make those choices in the context of the community, that what they do as an individual affects the rest of the community. And there's a community expectation that everybody should participate in things that we all generally agree are good for the health of our community. And certainly there are ways to sort of nudge those folks, keeping them out of school if they don't get vaccinated because they pose risks to the rest of society. Keeping them off airplanes because they can't travel because they pose risks not only to the people on the plane but to wherever they're going. So there are ways we can do that. But that's where public health comes in to say this is something that we can all benefit from. We can ratchet back some of our own individual ideas for the sake of a better society and for the public good.
Without presumption, do we advise other countries, say third world countries, about how to make their medical practices better for their populations?
Well, certainly we advise other countries on the public health aspects.
Okay.
We're not doing well on the medical care side. We have a great medical care system, but our financing mechanisms are not as good as they are in other countries. So it's difficult for us to educate others who are doing better than we are on the medical care side. But we do a lot of education on the public health side. The Centers for Disease Control and Prevention out of Atlanta is the premier public health agency in the world. And they have epidemiologists and policy advisors throughout the world looking at water and air and vaccinations and infectious diseases throughout the world, and sometimes going in with personnel to actually provide some services that are really helping change public health approaches throughout the world.
I think a lot of people probably, and having lived in Washington, D.C., and having friends at the NIH, the National Institutes of Health, et cetera, they told me they focus so much on research. And how long does research go on? I mean, we've initiated cures for certain diseases, et cetera, thanks to research, but is this going to be an ongoing thing forever?
Oh, yeah, it should be.
Okay.
It should go on forever because we are always learning new things. Okay. And there is always something new coming on board. We didn't have to deal with Ebola 30 years ago because we didn't know about it. We didn't, in the 1970s, we didn't know about HIV. And there are new activities. We also didn't know, but we didn't realize we're going to have so many refugees and immigrants throughout the world, which is a public health issue. And how do you address those needs? So research and how to deal with all of those issues is going to have to be ongoing. And as we get more tools, as we get more technologically advanced and more genetically advanced in terms of understanding genetics and all of these biological factors, we know more, so we can always take it to the next step. But also, we have to recognize that research can't just be on the diseases and how to treat a disease. We need to start looking at how to prevent some of these things from happening in the first place. And we put most of our research on sort of the cures and the treatment piece, and very little on the prevention aspect. So I've always encouraged the NIH to broaden their portfolio, to deal with a lot of the public health issues that also needs research. Maybe a different kind of research, maybe not bench research in a scientific laboratory, but research in communities that could really help us to improve health by having everybody not only get access to health care, but access to healthy food and access to transportation and access to safe, stable, and affordable housing, all of those factors that we need to research.
Yeah, on a personal level, about 5 years ago, I contracted chronic lymphocytic leukemia. And so I had the infusions of chemo. This is all at the VA, by the way, here in Minneapolis. And it was the oncologist, she was phenomenal. She knew exactly what to do. And I got into remission within a year for 2 or 3 years. Then all of a sudden it came back. But she told me, she was very prescient in her knowledge, just absolutely brilliant woman. But she said, I'm certain that if it returns, the cure is going to be with pills and not with infusions. And by golly, starting 2 or 3 months ago, I'm on pills and they are working. Mm-hmm. And it's because we had discussed research, and she said it's all because of research ongoing. And she said, I predict that someday all the chemo or chemo-related medication will all be in pill form, and people will not have to come in and get infused with the chemo itself. Do you see that happening too?
Well, I can't predict where things are going to go, but I do know that the human species is very curious and is always looking for what's new and how can we advance our health and well-being. And there are going to be new things that come down the road all the time. Mm-hmm. And it may not just be in pills. It may be something called nutraceuticals, where we actually have certain crops that actually come and help, that you can eat and help cure certain conditions. There are a whole variety of things that will be coming down the road. We can't predict, but I just know that our health care, the treatment we have right now, will be markedly different in 20, 30, 40 years. It has been, as I look back on my career in medicine, what we did back in the 70s when I graduated from medical school and what we do now are markedly different. We didn't know about some of the diseases, we didn't know about some of the treatments that we're now using that are just par for the course today.
When you were in rural Montana, and quite a bit of Montana is rural, as we know, beautiful state, wonderful people, but did you discuss with any of your patients who were farmers or ranchers the subject of nutrition and what they were growing and how they were growing certain foods having to do? I know there's one that was developed here in Minnesota. It's called triticale, but it had been developed by the Romans way back in time, and then all of a sudden it migrated to North America somehow, some way. But here in Minnesota, they developed a stronger version of triticale. Did you discuss that ever with your patients?
Well, I mean, in Montana, mostly it's wheat and cattle.
Okay.
And so,
sure.
Yes, we certainly talked about how it impacted their health and the global markets for wheat and cattle. But it's been much more, the conversation has been much more intense here in Minnesota, where we have a different climate and can grow a whole variety of things. And recognizing that the way we have set up, as I mentioned, industrial agricultural, it's basically row crops and corn and soybeans, that doesn't allow a lot of fruits and vegetables that are indigenous to this area to be grown, and how that really impacts health, how it impacts the local economy. And you've seen, I'm sure over the last several years, really a much more focus on locally grown, locally produced, farm to school, farm to table kinds of approaches, where we're actually growing things in Minnesota that come into the schools, come into your homes, come into the restaurants, supporting the local economy, but also improving the quality of the food and the nutritious aspects of the food.
Yeah, I was very blessed to be part of that triticale evolution up in Perham, Minnesota.
Yeah.
And I named the company International Nutrition and Genetics, meaning INAG, of course, was the acronym. And I think it still exists, I don't know, but even way back then, I mean, when I say way back, that was about 1983 or 84, something like that. And one of the people eventually went to Europe and really helped them with their nutritional education.
Mm-hmm.
How did you get interested in medicine, and when?
Well, I mean, I remember very early on in my career, I read the book The Other America by Michael Harrington. That book highlighted the fact that we had, he wrote it in 1962, and it was actually, it formed the basis of John Kennedy's War on Poverty. And it highlighted the fact that there were 40 to 50 million people in this country that didn't have access to care, that didn't have access to food, didn't have access to housing. And so I thought the best way to address that, the other America, was to go into medical care. And I learned that medical, again, as along that process, learning that medical care was just a piece of the reason why these people were in poverty, why they didn't have access to care. It was because of social and economic policies. And that's why I sort of tried to bridge medical care, public health, and public policy as a way to improve health.
So how old were you when you decided you were going to
I was in high school. You know, when I saw what that book highlighted and the response that the war on poverty had, that actually had been from 65, in 64 and 65 when the war on poverty started and until the mid-70s, had huge impacts on our health, improved our health. It reduced health disparities. It reduced poverty among senior citizens, improved access to care, and our outcomes were better in infant mortality and longevity than all the other industrialized countries. When we start dismantling those policies and those programs from the war on poverty, that's when our disparities started to increase, and that's when we started to fall behind other industrialized countries in terms of infant mortality and longevity. And that really said, that is where, yes, we need good medical care, we need good public health, but we need good public policy that focuses on social justice, that focuses on building community, that focuses on building the relationships that are necessary in communities to support everybody in the community, not just those with money.
We have about 30 seconds. I just want to ask, when you're dealing with the federal government, et cetera, do you ever feel more pressure than you did, say, when you were Commissioner of Health here in Minnesota?
Well, I try to work with the bureaucrats. I think bureaucrats are good things at times because they keep the ship moving forward. So when policies sort of go in a bad direction, the bureaucrats keep moving in the right direction. And so I work with a lot of the people in CDC and Health Research and Services Administration, SAMHSA, Centers for Medicare and Medicaid, to keep things moving forward until we get public policies that support public health and social justice.
Thanks so much for being here today, Ed, and I hope people will have learned a lot, which I'm sure they have, thanks to you.
I enjoyed my time. Thank you.
Thank you. And right now, shameless plug time, my book, Barry ZeVAN, My Life Among the Giants. It's on Amazon.com, and it has a lot in there that you would not expect to be in here. So I hope you will get onto Amazon. And we hope that you'll tune in next time.